Hello, my name is Ulrika Myhr. I'm a pediatric physical therapist working at Learn to Move in Sweden, and this is the second video regarding treatment of cerebral palsy. This time we're going to talk about creating movements. And this is a huge subject matter, so we are just going to touch upon it, but I think it's very important because when we talk about treatment of cerebral palsy, we talk a lot about spasticity, and spasticity is a certain movement pattern, much flexion of the arms and extension and toe walking, crisscrossing the legs. But we don't talk so much about the movements that will counteract spasticity. And instead of talking on what's too much, I think we need to understand that that's something that resembles the infant movement pattern, and that we need to understand how to gain the normal movement pattern. Because if we gain normal movements, we lessen the spastic movement pattern. In every position that I'm in, I have one part that's stable and one part that's movable. It's my trunk, my posture, that creates stability in sitting, in standing, in kneeling, in whatever position I'm in. And from the control of posture and the control of voluntary movement comes from totally different places in the brain. I can have high muscle tone of the extremities at the same time that I have low muscle tone of the trunk. It's very important to think about the trunk as well as the extremities. Well, what about the newborn? The first thing you learn to do is to control the head. And that's the first part of posture. And that's very important because the position of the head will affect the distribution of muscle tone in my whole body. If you think about it yourself, if you bend your head down, you sort of lose muscle tone. If you extend your head, you get high muscle tone. But it's much more so with the child. Also, if you have unequal distribution on the left and the right hand side of the neck, it will affect the rest of the body. Anyways, so if you have a child with severe CP that you may be put in a resting position because you say they cannot control the head, we have to allow them to sit up straight, give them support, and learn to control the head. This is something of great importance and something we will talk about more in a different video. Anyways, so this is the beginning of posture. Then we have the shoulders, we have the middle part of the trunk, and the last part is the butt, which is part of the trunk. The butt is part of both stability and posture, movement. If I can stand in kneeling, I have stability here. If I can move my leg and move it backwards, not only forwards in flexion, but backwards, then I have a great, then I can really prevent hip luxation, for example, where we have a lot of adduction and internal rotation. If I learn opposite movements, that's the key to preventing hip luxation, children with severe CP. What about creating movements with my lower extremities when I'm newborn? Well, a newborn can walk with infant stepping. It looks very much like a spastic movement pattern. They can crawl with a reflex, pushing from total flexion to extension. When you're about 6 months old, you start to isolate the movements in the knee flexion extension. You abduct the leg, you stand up, and you will do a lot of external rotation and abduction. Well, how can I teach a child that has a spastic movement pattern to find the movements that are difficult? One thing is to dorsiflex the foot. If I start early, it's a lot easier. For example, if I have a child sitting, even before they can stand up, I can hide a picture. I have a little bunny here under the foot, and the child can look at the foot. Because I can't feel much, I can use vision to enhance the movement. So maybe I knock on the foot, I say knock, 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 and the child give it some time, and they lift the foot up. Oh, a bunny rabbit. So by this time I learn dorsiflexion. So if I start early, it's much easier. Another thing that I commonly do if I have a young child is to put the feet in a box or whatever of sand or macaroni or beans, and I hide the feet or the foot. And where is the foot? Wait a minute. Start moving the foot just in any way, and then lifting the foot up, and maybe later on looking for things that I've hidden among the macaroni or the beans. And in this way I can see the foot, I get a response, and I can teach the brain to control the movement very quickly. Another thing that's very good to do when you have a child standing is to have pictures maybe of external rotation. If I have pictures, it's easier to find the movement. I think that most standing frames should place the feet in external rotation. If you stand with external rotation, you have much better alignment and much less chance of the knees kissing one another and the feet falling into, adduction or a valgus position. So we can also have a variation in standing, one foot in front of the other or whatever, but external rotation is of importance. I had a child who had a very difficult time walking sideways and doing that movement to begin with. He learned, but I said, well, let's go into a lower position, and I wanted him to move the legs in sitting out like this. He said, I cannot do it. So I put a bottle here. I said, can you knock the bottle? Immediately he could create that movement. So sometimes it's about finding that key to controlling the body. What about the hand of the newborn baby? Well, the hand is closed. We have a grip reflex, and the spastic child has a very much a closed hand, a fisted hand. Is that hand strong? No, it's not. We may think so, but it's not. And if you think about the newborn, they can learn to grab before they learn to release. When they're 3 months old, I can put something into their hand, they can hold on to it, but they will lose it with no control. And what I have learned is that if you have a spastic hand, you need to learn to grab before you learn to release. I may have to help the child with the wrist. I don't want the wrist to be here. I want it to be here. I can put kinesio tape or something different just to help with that. And I may even have to help with the grabbing itself to begin with. But I need to grab many different things of different sizes and different weights. Just to grab and release, grab and release. And when I can grab something heavy, this is called a stony, they come in 0.5 kilo and 1 kilo. When I can grab something heavy, what happens? All of a sudden, I can release. This I have seen many times when I start to learn just to grab and increase the weight, and all of a sudden the child will tell me, look, 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 I can release. And there is something similar with the foot. I want to tell you about a boy I once met. He was 14 years old, and he came to me and he said that he had one dead foot. He had hemiplegia. And in order to connect the foot with the brain, I taped his foot. You can also use these elastic braces, for sprained ankles, just to be able to feel the foot. And he said to me, oh, I could feel my foot on the subway the whole way home. And even though he was walking on his toes, he was not strong. He was weak. So he practiced strength of the gastrocnemius muscle, toe raises, lots of weight. And he actually learned to jump on one leg. He was very motivated. So what happened when he got so much strength that he could jump? Then he learned to walk on his heels. We had not practiced that. And what happens in normal development? Well, a 1-year-old child can walk on their tippy toes. It's quite common that they do so when they start walking. But they cannot walk on their heels. When they get enough strength to jump when they're between 2 and 3 years old, then all of a sudden they can walk on their heels. And so there is something about strength in grabbing that helps releasing. There's something about the strength in the foot of the gastrocnemius that will help with the dorsiflexion. Not sure exactly what, but that's what I can see, but I cannot read about it. Okay, sometimes we have to think a little bit differently. External rotation is something that can actually help the whole movement pattern. And I want to show you this orthotic, which in English is called twister cable. In Sweden we call it the derotational orthosis. So you connect this wire to a shoe and put it in external rotation, and a child that's walking with internal rotation and toe walking usually starts walking on the whole foot and with the foot in a good position. And when doing so, they will of course strengthen the hip muscles and the whole the normal movement pattern. Anyways, my first research study in the 90s was about this orthotic, and I was fortunate to have a legend in Swedish physiotherapy, Ingrid Odén, as my mentor, as well as Karin Harms Ringdahl. It was wonderful for me. And Ingrid had one of the first labs for children, and we measured the muscle activity without the orthotic. This girl had diplegia, she walked with a walker. We then put it on and measured the activity, and then we measured it again after 30 minutes. And after 30 minutes, she had absolutely normal activity of the gastrocnemius muscles and of the abductors. So by externally rotating the hip, her foot was affected. I recently tried this on a little girl, and the same thing happened. She started to immediately walk much better, and her mother said, "Why haven't I seen this before?" We are getting her own now, hopefully. If you don't have access to them, you can use, sometimes I use these fins you use when you swim in the ocean. Because if you walk with them, you cannot walk with internal rotation. You have to externally rotate. Of course, you cannot walk with these all day, but it can help you in practice, just finding that movement. All different ways of practicing that are fun are good. Okay, so what else? Well, we have a ball here. We can always think about the position I'm in when I'm creating a movement. For example, I'm hitting the ball here, but if I want the child to raise the arm up higher, I can maybe lie down on the floor and hit the ball. Then I have to raise the arm higher. I can, of course, raise the ball in small increments just to make me lift the arm higher, or I can lower the ball and hit it sitting on a high bench and practice that swinging part of the knee flexion extension like we have in walking. So depending on position, if it's difficult to create a movement in a certain position, and also with a certain weight. It's more difficult sometimes in a lower position. If I lie on my tummy to lift my leg up, that's more difficult than standing and lift my leg up. I can maybe lie on my back and lift the leg up and then try to turn and maintain the leg up so that I can lift it even when I'm lying on my tummy. We have to be creative when teaching movements. But why I wanted to talk to you about this is because I think we don't actually observe which movements a child can perform and what chance have we really giving them of learning to create that movement. I would love to have a million types of tasks with virtual reality and things like that, or feedback of different kinds when I create the right movement. But first of all, I need to understand which movements to make. And it's very, very good to understand how the flexed newborn baby gains posture and gains control of different movements so that I can imitate that. And also understand how I can increase strength in different movements. Okay, that was a little introduction to creating movements, something you and I take for granted. I hope you will have fun trying to figure out tasks for your child that will make him problem solve and create a movement that was previously difficult. Good luck and looking forward to seeing you next time. Have fun.